Hi friends, I am Dr. Ashutosh Gupta and I practice fetal medicine. तो हम fetal medicine का premise सिर्फ यही है कि that probably we try to identify कि we are able to identify all the congenital abnormalities to the fetus as soon as possible. So as I have told, and it is my firm belief that at 12 weeks we can be sort of very sensitive as far as the fetus is concerned, and then we try to look around for all the congenital abnormalities. But as far as the cardiac is concerned, many a times we've identified that probably whatever abnormality that we see at 12, so meaning thereby that we can be very sensitive. But the specificity of that particular diagnosis is being when we follow it out across at something around 2 weeks, yeah, 3 weeks down the line. So meaning thereby that something around 16, 17 weeks, the ultrasound, which we call as a genetic sonogram, it is very specific. And then whatever we are talking about, whatever congenital cardiac lesions that we're talking about, we are very specific about all scenario. And first thing is this, that we are specific. Secondly, we do have that ample amount of time that probably if we wish to investigate the baby on the lines of doing some invasive testing and some genetic evaluation, so probably we do have that time left onto our hands that probably we can do those evaluations. So today I'm going to show you a good case. It is a DADC twin with one of the babies having some cyanotic congenital heart disease, right? So I'll show you that slide. This is a 17 weeks DADC twin. So four chamber, both the valves, tricuspid, mitral, pulmonary vein, right? The LVOT, and then we can see we are trying to look around for the arches, both the ductal and the arch of aorta, right? And then this is the affected baby. So look closely, we can identify the VSD. So it is a big VSD. What we are identifying is a thickened tricuspid valve. We are struggling to see the LVOT. So I could identify none, right? And then I am trying to juggle up with the LVOTs and the RVOT, and suddenly we identify that those vessels are parallel to each other. So and then I follow it out across and identify that both of them are arising from the right ventricle. So it is a VSD, thickened tricuspid valve, DORV. 16 वीक्स पे जब जेनेटिक सोनोग्राम करते हैं तो वी आर वेरी स्पेसिफिक. सो वट एवर वी आर टॉकिंग अबाउट, वी आर वेरी श्योर अबाउट द डायग्नोसिस दैट वी आर टॉकिंग अबाउट. First, secondly, what we can identify is this, that the outflow tracts can be looked around very well, and then we can identify what we are dealing up with, right? Okay, so we have had a sort of a big VSD. We had a thickened tricuspid valve. So both we could not identify the LVOT arising from the left ventricle. So both the great vessels were arising from the right ventricle, and therefore, and both the vessels, they were parallel to each other. Therefore, the diagnosis of a double outed right ventricle was being made, right? Now DORV is the second commonest sort of an cyanotic congenital heart disease, right? But definitely the baby, depending upon the clinical situation, the baby shall present with cyanosis at birth, and then the baby would definitely need a cardiac surgery after the baby is born, and therefore the baby pertinently needs a tertiary care hospital sort of in care, and the pediatric cardiology services should be available. Secondly, we before going that further up, what we have offered them is this, that we can do the amniocentesis and try to look around what is the exact chromosomal status to the baby. Third, since it is a DADC twin, and then uh, they were not very keen on doing those invasive testings. And then what if it turned out to be abnormal, and what if it turns out to be normal? So if it turns out to be abnormal, then also a fetal reduction would be done. And if it is normal, for all practical purposes, the baby would need a pediatric cardiac surgery after the birth. So meaning thereby that there is a lot of dilemmas and a lot of there are a lot of options, as a matter of fact, being available to the couple. So meaning thereby that it is not that easy being to tell them that probably we are dealing with all these things. So these are different options, meaning thereby that we can do a fetal reduction outrightly. We can offer them an amniocentesis and don't look around for the chromosomal microdeletions. And if they turn out to be abnormal, then probably we can do a reduction. If it is normal, then probably we can proceed with further up with the pregnancy. And definitely the baby would need a surgery after the baby is born, right? So these are different options that is available to them. Thank you very much for your patient listening.